Happy afternoon, everybody. So if everybody is joined, we can start the session.
Happy afternoon, ma'am. Dr. Nisha here. So with your permission, ma'am, I'm beginning the presentation.
Yes, please start.
So we'll be discussing pathophysiology of male reproductive system today. And as we all know that infertility is on rise, but for the past few decades, female infertility has been given importance, and male infertility has gained in importance in past 2 to 3 decades. And today we'll be discussing on that. So as per WHO,
please put it in a slideshow mode so that everybody can see it properly. Yeah.
So as per WHO, infertility is defined as a disease of the male or female reproductive system defined by failure to achieve a pregnancy after 12 months of or more of regular unprotected sexual intercourse. Male infertility contributes to 50% of the problem in infertile couples, with male factors sole contributing to about 30 to 35%. Now, regardless of the genetic advances, the etiology remains unknown in 50% of the cases, and it is known as idiopathic infertility. Although a lot of information has been gained on male infertility part, where we have gained so much on DNA fragmentation and genetics, we have progressed, but regardless of it, when we see the semen parameters, all the parameters being normal, still we have some factors which contributes to male infertility, and those are put under idiopathic infertility. But as the science is progressing, we are able to categorize these idiopathic infertility also into certain, we are having some etiologies like reactive oxygen disease or DNA damage, and we are able to identify some of the causes. Coming to the gross anatomy of the male reproductive system, the semen is produced in the testicles in the seminiferous tubules, which has the interstitial part and the seminiferous tubule part. The seminiferous tubule has the Sertoli cells and the germ cells, as well as the interstitial part has the Leydig cells. So after the production of the sperm, it goes into the lumen of the seminiferous tubules and travels via the rete testis and enters into the epidermis, which has 3 parts: the head, the body, and the tail, and where it gains the motility, and it traverses via the vas deferens, and it is joined by the secretions of the seminiferous tubules, and the prostate glands travels via the ejaculatory duct, joins the prostatic urethra, and this is how it further ejaculation takes place. So coming to the hormonal regulation of the testicular function, it is at 3 levels: the hypothalamus, the pituitary, and the gonad, which is the testis. So hypothalamus contributes by releasing the gonadotrophin releasing hormone, which triggers the anterior pituitary gland to secrete LH and FSH. LH acts on Leydig cells. LH acts on the Leydig cells, and it produces testosterone. Now this testosterone most of it enters into the seminiferous tubules, and the concentration here of the testes is 50 to 100 times more than what it is in the blood serum. And the FSH, which is secreted, it acts on the Sertoli cells, which is responsible for nurturing the germ cells. And as the spermatogenesis takes place, the Sertoli cells, it secretes inhibin, which down regulates the secretion of the FSH. The Sertoli cell is also responsible for forming the albumin, the testosterone binding protein. So the testosterone which enters the circulation also binds to the serum binding protein, and whatever is left is the free testosterone. And Testosterone itself controls the secretion at the level of the hypothalamus and the pituitary by down-regulating the secretions of the gonadotropin. So this is a very basic how the hormonal controls takes place at the hypothalamic pituitary gonadal axis. So what is the aim and objective of?
1 second, Dr. Nisha. Brief explanation about the embryology also, I think at this stage will be better.
Yes, ma'am. So the germ cells, as we know, it develops into the dorsal part of the yolk sac and it traverses through the hindgut to the mesentery to the gonadal ridge. At this stage, the population of the germ cell is around 3 lakhs, and when it reaches the gonadal ridge, it proliferates, and this gonadal ridge further grows and is surrounded by the interstitial mesenchyme, which has the Leydig cells, and the seminiferous tubules grows in, and the seminiferous tubules has its origin from the nearby epithelial cells, and after the tubules are formed, these germ cells get surrounded by the epithelial cells, and this is how the gonads will form, and the population will be from 3 lakhs, and the per day in contrast to the female germ cell the division in the male, it starts during puberty, not in the intrauterine life. It starts during puberty under the influence of these gonadotrophins.
Okay. And during spermatogenesis, just can you just brief the spermatogenesis procedure also?
Spermatogenesis, the germ cells undergoes first the mitotic division. Now this germ cell is a diploid cell, meaning by it has 2 pairs of chromosome in it. And after first mitotic division, the first primary spermatocytes form, which further again
spermatogonia undergo mitotic division. There are 2 types of spermatogonia, type A and type B. I hope you all guys know that. Then primary spermatocytes are formed. Please go ahead. Yes.
Then secondary spermatocytes form. Then first meiotic division, wherein by the spermatocytes are formed, and this further goes into second meiotic division, and 4 spermatids are formed, which are haploid.
Okay. Please go ahead. And then maturation occurs into sperms. This spermatids are matured into sperms.
After the
differentiated, yes.
After the spermatids are formed, they are expelled into the lumen of the seminiferous tubules, and it gains its maturation there and motility in the epididymis.
Yeah, they develop a tail and they lose a lot of cytoplasm. That is called differentiation. Okay, please go ahead.
So the basic reason for studying male infertility is for evaluation of the infertile male should be directed towards achieving all of the following goals: to identify and to correct specific causes of infertility whenever possible, to identify individuals whose infertility cannot be corrected but can be overcome by IUI or other forms of ART, to identify individuals having genetic abnormalities that may affect the health of the offspring and that may be conceived during the use of any form of ART, to identify individuals whose infertility can neither be corrected nor be overcome by ART and for whom adoption or donor sperm is the worthy option. And also, lastly, to identify any important underlying medical condition which may initially present as infertility. So coming to how we diagnose, taking history is very important in male infertility cases because a lot of men will ignore important points relating to their occupation or other relevant exposure that may harm the sperm quality. And we have to be very cautious while taking the history. So while history will take these following points, the duration of infertility, and first it should be the duration of marriage and whether the couple has been cohabiting together during the entire marital phase. So whereby we'll come to know the duration of infertility and whether there was any previous fertility by the same partner or any previous partner, coital frequency and other coital problems if the couple has, like sexual dysfunction in the men, erectile or ejaculatory dysfunction, results of any previous evaluation or treatment that the man would have taken, any childhood illness or development problem that he may have, any surgery that may he have undergone in the earlier days, like hydrocele or any pelvic surgery. These are important. And exposure and past episode of exposure to sexually transmitted infections. We have to ask them if he has any genital symptoms that can have a detrimental effect on the sperm quality. Occupation and environment exposure to deleterious factors, current medication or allergy to anything, occupation and use of any tobacco, alcohol, smoke, or any marijuana or any abusive drugs. Physical examination, we must examine the external genitalia of the man, where we examine the penis, and we also like to examine the position of the urethral meatus, palpation of the testes, and measurement of the size. We should also look at the consistency of the testes, where it can be hard or firm in cases of malignancy, soft and streak-like in cases of genetic diseases like Klinefelter's and all. Presence and consistency of the vasa and the epididymis. This we do by palpating the spermatic cord, where the vasa has a slippery feeling. And epididymis is usually not palpable, but in cases of obstructive azoospermia, this may be distended and we may be able to feel it. It may be painful if it is infected. And presence of any varicocele. Secondary sexual characters, which would include the body habitus, hair distribution, breast development or any secretion from the breast, and digital rectal examination, which is important in knowing the seminal vessels and the prostate, and if there is any cyst in the ejaculatory duct, or it is painful in cases of prostatitis, or so digital examination is very, very important. So coming to the causes of male infertility. So I have taken the help of Speroff's and Dr. Kamini Rao's book. So I will be classifying the male infertility as per it is given in the Speroff. So causes of male infertility are: first, hypothalamic pituitary disorders, which constitutes 1 to 2% of the problem. Second is the primary gonadal disorders, which constitutes 30 to 40%. And disorders of the sperm transport, constituting 10 to 20%. And vast majority is idiopathic, which constitutes alone 40 to 50%.
This is in short pretesticular, testicular, and post-testicular. It's the same. And idiopathic, of course, when the cause is not identified. That is it.
Yes.
Yeah.
So coming to the hypothalamic pituitary disorders, naming few of them is the Kalman syndrome, idiopathic isolated gonadotrophin deficiency, hypothalamic and pituitary tumors, infiltrative diseases like sarcoidosis, hemochromatosis, histiocytosis, hyperprolactinemia, drugs, critical illness and injury, chronic systemic illness, all malnutrition, infections like meningitis, which affects the pituitary and leads to gonadal dysfunction, obesity, and single gene mutations like mutation in the receptors of the GnRH or FSH or LH. Primary gonadal disorders, Klinefelter's syndrome, Y chromosome deletion, cryptorchidism, varicocele, immunological causes, infections like tuberculosis, viral infections like mumps, leprosy, then drugs like alkylating agent, alcohol, androgens, cimetidine, radiation, environmental gonadotoxins like heat, metal, pesticides, and organic solvents. Disorders of the of the sperm transport is obstructive and subobstructive lesions, congenital bilateral absence of vas deferens, infections causing obstruction of the vas deferens like gonorrhea, chlamydia, tuberculosis, cartilaginous syndrome or the primary ciliary dyskinesia, vasectomy, Young syndrome, and ejaculatory dysfunction or the erectile dysfunction, sexual dysfunction. So we'll be briefly discussing about them. Coming to hypothalamic pituitary disorders. So Kalman syndrome. Kalman syndrome is one of the most common causes of hypothalamic pituitary disorders, giving rise to male infertility. It results from failure of secretion of GnRH by the hypothalamus and leading to lower gonadotrophin levels, leading to failure to transition from prepubertal testes to postpubertal level of function. So basically what happens here is the olfactory neurons and the GnRH secreting neurons, they fail to migrate or secrete. So if there is a failure of migration with the olfactory involved, then there will be anosmic Kalman syndrome. However, if the migration of the neurons is normal, but the secretion part has been hampered, it will lead to osmic, or there won't be problem of the olfactory region. So GnRH deficiency happens. So GnRH deficiency results in failure of embryonic migration of the neuroendocrine GnRH cells from olfactory epithelium to forebrain, and absence of hypoplasia of olfactory bulb. As I explained, it will lead to anosmia. And there are several genes that has been identified in this syndrome, and CAL gene 1 and is the best studied, followed by fibroblast growth factor receptor 1 gene. So clinically, if a man with this syndrome comes, clinically, if we look at him, we can know it can present as anosmia, azoospermia, gynecomastia, tall stature man they will be. On examination, gynecomastia, cryptorchism, micropenis, and azoospermia on semen analysis we will see. On ultrasound, unilateral renal agenesis may also be there. Second is Prader-Willi syndrome. This is caused by microdeletion or mutation on the paternal chromosome 15. And this is a very severe form of disease, and it hits right from the childhood to adulthood. And so these patients usually have concurrent many medical problems, and they hardly have any interest in infertility. However, the clinical features will be infantile hypotonia, obesity, cryptorchidism, short stature, and they will be mentally retarded. Third is hypoprolactinemia. This is very much not very common, like in the female infertility part it plays, but the cause is prolactinoma. Now in female, when the prolactinoma is there, it is usually small, micro prolactinoma, whereas when it happens in male, usually they are macroprolactinoma, and the prevalence in men is around 11%. So what happens is the excess of prolactin that is secreted, it decreases the LS secretion pulse frequency, whereby hampering the testosterone secretion. So the clinical feature will be sexual dysfunctions like loss of libido, retrograde ejaculation, impotence, decreased sperm count, and motility. Galactoria, gynecomastia is not very common because the breast development is under the estrogen. Usually don't present like that. Coming to infiltrative disease. Infiltrative diseases of the hypothalamus or the pituitary, like sarcoidosis, histiocytosis, transfusion siderosis, hemochromatosis can inhibit GnRH or pituitary gonadotrophin. This happens because these infiltrating things, they enter the cells and hamper the gonadocytes in releasing those factors, and this is how it happens. So clinically, the patient will complain again of impotence, loss of libido, hypoandrogenization, and reduced testicular size if it has happened in a very early stage, the exposure. Histological sections of the testes show hypospermatogenesis and absence or reduced Leydig cells. Obesity. It is rampant and we are seeing it so much. So first, what happens in male obesity? It affects at hypothalamic, pituitary, testes, and the fatty tissue. Everywhere it is working. So in the fatty tissue, because of the excessive fat, there is hyperinsulinemia, which decreases the sex hormone binding globulin, whereby and there is aromatase conversion of the estradiol, the excess of the testosterone to estradiol, and this estradiol will work on the hypothalamus and will decrease the GnRH secretion. Now, because of at the level of the hypothalamus, there is this excess of estradiol, increased leptin, hyperleptinemia, and hyperestrogenism. These all will work at hypothalamus, will reduce the GnRH secretion. So pituitary, we will find the FSH-LH going down, and because of this, the testicles will be affected. Of course, FSH with decreased supply in the Sertoli cells will hamper the spermatogenesis process. As we know, the testes had dual functions, spermatogenesis and steroidogenesis. So both are going to be affected here. So Sertoli cells, the FSH won't be too much, and LH won't be getting, Leydig cells will not be getting too much of LH. So both ways, the germ cells, production of inhibin and sperm cell production, everything will go down, and Leydig cells won't be able to produce much of the testosterone. So finally, we will have impaired sperm function, infertility, and it is, as I said, that infertility is very common. So if a mother who has been obese at that time, so epigenetic inheritance can also be there. And all this will culminate in infertility. So effect of obesity will be physical effect. There will be increased erectile dysfunction, increased scrotal temperature, increased sleep apnea. So what is the effect it is going to have? So increased scrotal temperature, like it will be the huge abdomen and between the thighs, all the temperature is increased, and the DNA fragmentation is more because of the heat. Sleep apnea, it decreases the LH pulse frequency, and that's how testosterone levels goes down. The seminal effect, we will see oligospermia, increased TFI, decreased seminal volume. Hormonal, we will see increased estrogen, like I said, in that at the level of adipose tissue, it will go on. Insulin, hyperinsulinemia, hyperleptinemia, and both of these will go at work at the hypothalamus level, decreasing the GnRH, and decreased testosterone because LH frequency has gone down.
One second. You told us there can be DNA damage. If you see practically, whenever a male person we see an obese patient, we do a DFI for them, and it will usually be high. Dr. Nisha, can you explain the mechanism by which you told that there is increased DFI and increased? Can you tell me the right? Right. One mechanism is oxidative stress, which causes DNA fragmentation. There are also studies which show that the packaging, there is a packaging defect when histones are loose and protamine deficiency is also seen in
Yes, ma'am.
diabetes. That is why there is packaging defects
Yes,
also.
ma'am.
These two are
Yes.
the mechanisms mainly.
Yes, ma'am. As we know that the human in human the chromatin packaging is deficient in uh, protamine. We have more of 10% more of histones, which is a very unstable kind of packaging, and inherit the strands are broken. So all these factors which are already present leading to all these added factor, we see more DFI fragmentation in these men.
Yeah, go ahead. Go ahead.
So coming to primary gonadal disorders, Klinefelter, one of the most common that we see. It is an aneuploidy with an excess of Y chromosome. So aneuploidy is the most common chromosomal error identified in infertile men, and the most common of these is XYY chromosome. However, several combination of mosaicism is also seen, and as the mosaicism varies, so does the phenotype. So by and large, these men will be having small and firm testes because it is genetic. So right from the beginning, so testes won't grow, and it will be small firm testes resulting in damage of both seminiferous tubules and Leydig cells. It is a non-obstructive azoospermia factor, and testicular atrophy is the main feature. The FSH
What?
LH. Yes, ma'am.
Oh, 1 second, Dr. Nisha. What is the aneuploidy seen in Klinefelter syndrome?
It's XYY, ma'am. Means additional
It
copy
is.
of the Y, ma'am.
Is it a double XY?
Yes, ma'am. I'll check on it, ma'am.
Double XY.
I'm sorry. Can anybody answer? Like, isn't it double XY? I can see many
Yes,
other fellows are there.
XXY, ma'am.
Yeah, that is the most common aneuploidy, right? Of course, mosaicism and all are there, but
Yes,
it's not
ma'am.
XYY. It's double
XYY is
XY.
that Jacob's syndrome or something, ma'am.
Yeah. It's entirely another issue. Here we have an extra X chromosome.
Yeah, it's
not
an additional copy of the X chromosome.
Yeah, go ahead. And also, I wanted to tell you that time itself. What is the incidence of hyperprolactinemia in female population, reproductive age group? You told it is 11% in males, which according to you is higher than in females. What do you think is the incidence in females, hyperprolactinemia?
Uh, Not sure, ma'am.
It is 5 to 14% in reproductive age group. Most of the incidences we see are false because we just measure once, and the criteria for measuring prolactin are not appropriate. So when you actually measure, and the worldwide incidence is just 5 to 14%. Okay.
Yes,
Go
ma'am.
ahead. Please correct this. Yeah, go ahead.
Yes, ma'am. So here the FSH LH levels will be high, and the testosterone production is not though, so it will be very, very low. So we can do a fish test study to show loss of genetic integrity of the gamete, and hence chances of normal embryo here is very, very low. So this is important that we do a genetic counseling here in these patients, diagnosed patients, so that we can inform them completely about the cause of infertility, and if they go ahead with any form of ART, what will be the chances of the progeny having the same problem. So testicular dysgenetic syndrome. This was proposed by Skakekby in the year 2001, and this group of scientists, they had observed that the testicular, they formulated this terminology of testicular dysgenetic syndrome, which is defined as a group of condition that represents a syndrome of disorders and usually caused by similar underlying entity which leads to disturbance in the testicular development during fetal life. They have no clear etiology, but rise in a few generation indicates environmental changes and changes in the lifestyle instead of genetic factor as the likely cause. So it is our lifestyle factor related mostly. So the various environmental factors and also backed by the genetic factors, it leads to the genetic testicular dysgenesis, and which causes problem at the level of the Sertoli cells and the Leydig cells, whereby impairing the germ cell differentiation and decrease testosterone production, and it leads to, and it is leading to the reduced sperm quality, more rise in testicular cancers, hypospadiasis, and testicular maldescents. Cryptorchidism. So it is the most common congenital defect in male newborns, failure of the testicular descent during fetal development. Testicular descent is androgen and androgen receptor and insulin 3 and G protein coupled receptor dependent process. First phase is insulin and G protein coupled dependent, while the inguinal descent, it is depending on the androgen and the receptors. Increase intra-abdominal pressure. If the testicles do not descend, the increased abdominal pressure causes damage to the seminiferous tubules and the germ cells. And because of the vulnerable position that the testes has at the root of the scrotum, it is more likely to have torsion or trauma. Y chromosome microdeletion. It is a relatively common cause of severe oligospermia, 2 to 5%, and azoospermia 8%. Now there is a region, the azoospermia factor region, which has 3 subregions, azoospermia factor A, B, C, and these regions are on the long arm of the Y chromosome, and it contains 2 genes, DDX3Y and USP9Y, which are important for the spermatogenesis process. So if a person has azoospermia factor A, B mutation present, then the chances of retrieving sperm in PISA or any surgical technique of retrieving the semen, it will be very, very less. However, if AZFC is present, then 50 to 60% chances are there that we may retrieve the sperm. So using micro-TISA, viable sperm retrieval is seen in AZFC factor in 50 to 60% men. Testicular biopsy is not recommended in azoospermia factor A and azoospermia factor B mutation, as retrieval rate is essentially 0. And here there is a role of genetic counseling, as it is transmitted to the male progeny, who is also probably will be an infertile male. Coming to varicocele, it results from dilatation of the pantheniform plexus of the spermatic vein in the scrotum. Prevalence of primary infertile men is around 35%, and secondary infertile is 72.
What do you mean by primary infertile and secondary infertile here?
Ma'am, here it does something wrong I've written, ma'am. It means that the varicocele is very common. The prevalence in the infertile men is around 35%, and on the fertile men also we can see and 70 to 85%.
You mean to say in normal population the prevalence of varicocele is 70 to 85%?
Not so high, ma'am, but
I think whatever statistics you have put from somewhere. I think I haven't read it, but I think what you mean here is for the couple who are presenting with primary infertility, the instance can be 35%. But even as I say it, I feel even that is high. I don't know where you have got the statistics.
I took it from Speroff only.
Please, yeah, please refer and get back to where. If you have read from Speroff, then it must be correct only. But whatever stats you have put, it doesn't make any sense. Just
Yes.
please get back to me on this here. Go ahead.
Yes. So the mechanism likely associated with asthenospermia and oligospermia in cases of varicocele, increased testicular temperature, delayed removal of local toxins, hypoxia, and stasis. Torsion. It is a surgical emergency caused by twisting of somatic cord and
Can
its
you just go back to the last slide? Can you just go back to the last slide?
Yes, ma'am. Varicose.
Okay. Okay. Here also, I think what happens in varicocele, we all know there is increased temperature. The temperature of the testis increases. What happens with increasing temperature? What is the mechanism?
Ma'am, it is there are other factors also affecting playing part in
I understand.
varicocele.
Yes, yes, I understand that. There are other factors like there is DNA damage. There is again ROS production because of, like you have said, delayed removal of toxins. ROS is not removed properly. That is there. But increased temperature is also one of the factors. Even in cryptorchidism, that is also one of the factors because the testis is exposed to abdominal temperature.
Yes,
There is a mechanism where there is a study which says that sperms developing in high temperature in the testis, when the testis is exposed to high temperature, they are more subject to denaturation. That is, the DNA damage will be much higher in those. So in varicocele patients and obese patients and all these patients where their testis is exposed to high temperatures, the DNA denaturation is much higher. The sperm
Yes.
is more sensitive to denaturation. Yeah, go ahead. Next.
So torsion is a surgical emergency caused by twisting of the spermatic cord and its contents. The mechanism by which it is causing testicular deteriorations are cellular hypoxia and ischemia and reperfusion injury, microcirculatory changes, leukocytosis and or endothelial interaction, reactive oxygen species production, germ cell apoptosis, post-inflammatory obstruction, and activation of the proteolytic enzymes. Coming to the drugs, there are several drugs categorized like antihypertensives, in which the alpha blockers, beta blockers, diuretics, they are known to cause the defect at the fertilization level, at the with the fusion of the sperm and the oocyte membrane. Then the chemotherapeutic agents like cyclophosphamide, busulfan, cisplatin, and psychotropic agents like lithium, SSRIs, antibiotics, hormones, and colchicine and allopuranols. Immunological, that is the anti-sperm antibodies. It constitutes of 3 to 13% of the immunological factor infertility in men. And it is the reason is the breach in the blood testicular barrier, leading to the immune system targeting the sperms, and it produces the antibodies which harms the sperms. So what are the causes that leads to breach in the blood testis barrier are any surgery like vasectomy done or biopsy taken, trauma, torsion, infection, inflammation, testicular cancer, or by any means if these the blood testicular barrier is breached, the sperm is the immune system is exposed to the sperm, which treats it as a foreign object, and immunoglobulin is produced. So basically IgA and IgG immunoglobulins are produced, and they have a cytotoxic agglutination and immobilization impact on the sperm. It also prevents cervical mucus penetration and oocyte sperm fusion. The result is considered positive if 50% of the sperms are coated with this antibodies. Disorder of the sperm transport. So main is the obstructive lesions. These include obstruction and subobstruction lesions of the seminal tract, inflammation, which is inflammation and infection of the accessory glands. It is acquired form that can be because of the infection earlier or inflammation, and these are commoner than the congenital causes. And there is usually no reduction in the testicular size as sperm production is normal. The obstruction can be at the level of epididymis, vas deferens, ejaculatory duct, or functional obstruction. Coming to congenital bilateral absence of vas deferens. Congenital absence of bilateral vas deferens leads to blockage of transport of spermatozoa from testes to the epididymis to distal genitourinary tract, caused by mutation in cystic fibrosis transmembrane regulatory gene located on chromosome 7 that encodes the CFTR protein involved in chloride conduction across epithelial cells. Epithelial cells present in the lungs and the pancreas. Severe mutations are lethal, and mild mutations present with CBAVD, 1% of the infantile men. However, the prevalence is varying. Sperm retrieval from testes and epididymis coupled with ICSI can be performed. Genetic testing for CBAVD mutation is obligatory for patient and also for the spouse, as silent carriers in the female is also seen in the ratio of 1 in 25 individuals. However, these prevalence, they vary from region to region. Coming to Young syndrome, the CBAV when association of congenital bilateral absence of vas deferens with obstructive azoospermia and chronic sinopulmonary disease is known as Young syndrome. There is no increase in CFTRE gene mutation in these patients, and it appears to be cystic fibrosis independent disorder and often seen in mercury poisoning in childhood. Inflammation. The key mediators are the pro-inflammatory cytokines like interleukin 1A, 1B, and tumor necrotic factor alpha. It affects the dual function of the testes, hampering both spermatogenesis and steroidogenesis. In inflammatory states, the oxidative stress is generated by infiltrating the leukocytes and cytokines, and it leads to overproduction of the reactive oxidative species, and non-regulating epithelial cells lining the epididymis and the testes are vulnerable for scarring and stricture formation, and may also involve the ejaculatory duct. Coming to infection.
Have you ever heard of cartaginous syndrome?
Yes, ma'am.
Can you explain?
Ma'am, cartaginous syndrome, it is involvement of the.
It is involvement
Yes, ma'am.
of.
In this, the men will have the upper respiratory tract infection as well as like the recurrent rhinitis, sinusitis, and they will be coming regularly to the OPDs for these upper tract infections and everything, and they will be associated in fertility, and it is.
See, the other name of cartaginous syndrome is primary ciliary dyskinesia, right? There is no ciliary motility for them. Sperms will be there, they will have infertility because the sperms are not motile, motility problems. Okay, and yes, they will have this, because they are having ciliary dyskinesia, they will be more prone to upper respiratory tract infections and all that. But more than that, there is something called situs inversus, like entire organs will be right and left.
Yes.
Okay, yes. Please go ahead. Next.
Infections. So infectious organism can directly harm the sperm membrane or through inflammatory process inherited with the infection or due to release of the toxins. Direct effect of pathogens may lead to infection, like in E. coli infection. The E. coli adheres to the spermatozoa and leads to agglutination. The Uroplasma urolithecum impairs sperm nuclear integrity. HBV virus causes loss of sperm motility due to triggering of loss of mitochondrial membrane potential. Viral orchitis is as caused by paramyxovirus or Coxsackie or varicella or lymphocyte choriomeningitis. The mode of infection is through the blood, and it causes infertility because of the pressure necrosis of the seminiferous tubules due to the parenchymal edema within these testes. So infection causing male infertility is by the following mechanism: affects the normal function of the male reproductive system, disrupts the blood testis barrier, semen parameters, they are changed, it disrupts normal morphology, biochemistry and sperm function, excess of reactive oxygen species production, impaired sperm oocyte interaction, impairing accessory gland and normal function, and duct system occlusion. So here we will just outline how the oxidative stress is causing problem with the infertility part. So the pathological factors of the male reproductive system, like infection in the accessory glands or abnormal forms of sperm being formed or immature spermatozoa, prolonged stasis of the spermatozoa in the epidermis, like in varicocele or in case of torsion, they all lead to overproduction of the oxidative oxygen species like nascent oxygen or hydroxyl ion or hydrogen peroxide ions. And similarly, by the environmental factors like drugs, smoking, pollution, radiation, then any systemic disease like obesity, diabetes, cancer, recurrent infections, these all lead to formation of these reactive oxygen species, leading to oxidative stress. Now this reactive radicals, they will work on the DNA, and it will cause injury. Directly injures the urine and the pyrimidines and leads to breakage in the single double stranded DNA, causing DNA damage. At the level of mitochondria, it damages the mitochondrial DNA, and it decreases the ATP production, thereby causing the hampered motility. Then working on the sperm membrane, it causes lipid peroxidation of the unsaturated fatty acids. So we see that how these the reactive oxygen species, they work at DNA, mitochondria and sperm membrane, and they cause damage. So in past few years, a lot of studies have been done on the antioxidants to prevent these injuries. Some of them I will see. Vitamin E, it lowers the lipid peroxide oxidation. It protects sperm from loss of motility. So the motility is improved. It was studied by Verma and Kanwar. Similarly, isoflavones, they protect from H2O2, the hydrogen peroxide, and induced DNA damage. Vitamin C, E, zinc, beta carotene. Vitamin C expresses gene involved in intracellular redox pathway. So the self scavenger system, it promotes that. So there is a decrease in the DNA damage. So people who were taking it for 2 months, it was studied that the sperm DNA damage, it lowered from 22% to 9%. EDTA, which is commonly added while doing the centrifugation process, it reduces the redox, the degeneration of the ROS while centrifugation, and meanwhile the parameter that is protected is motility and DNA integrity. Minivit, which is a collective zinc, vitamin C, E, and selenium. So they are seen to decrease the ROS production and increase sperm protamination, and minimum 3 months of intake. The ICSI rate, the success of ICSI was around 39%. Then glutathione, which was given 600 milligram alternate days, it showed that it protects plasma membrane from lipid peroxidation and scavengers, and from the scavengers like superoxides, and the parameter morphology increased in men with varicocele and infections. Similarly, selenium with vitamin A, vitamin C, vitamin E, the selenium increases glutathione peroxide expression, which scavenges the H2O2 molecules, and the motility is improved. Folic acid, zinc, it reduces homocysteine levels and improves concentrations of the sperm. Pentoxifylline, it increases sperm motility, hyperactivity, acrosomal reaction by increasing intracellular cAMP levels, and motility is improved. So with this, I conclude my presentation.
Hello?
Yes, ma'am.
Am I audible? Because I
Yes,
cannot
ma'am.
hear you guys properly. Yeah, I think that's the end of the presentation.